I invite our first speaker, Dr. Chandra Mohan, to take over, starting with flexible ureteroscopy in a very special situation, that is in very young children. Dr. Chandra Mohan.
Thank you very much, Madhusudan sir, for introduction. I thank SIU and Urology Society of India for giving this opportunity. RIRS in infants is a special situation where it is difficult to manage with small prostate, the pediatric urethra, bladder and ureter. Safety of ureteral access sheath, dilatation, intrarenal pressures are concerned. Anesthetic risks are there. How to tackle pediatric sepsis? How do you choose the case? These are important. Infants we are considering as less than 2 years here. Pediatric stone incidence is increasing. 2 reasons: the diet habits and the incidence of detecting ultrasound based. Ultrasound is commonly used now. Treatment guidelines are constantly changing. The AU and EAU in children has already adopted RIRS as one modality in less than 1.5 centimeters. ESW and PCNL for a long time are the standard of the care. Recently, RIRS has come as an alternate option, less complications and comparable SFR, but technically challenging. So, the handle small urethra and ureter is the major concern. Another concern is they may recur. 90% of the times metabolic abnormalities may be there. So you have to keep in mind when you are puncturing, when you are going into the ureter. Anesthesia in small children less than 2 years is difficult. Caution regarding damage to the developing kidneys as far as ESWL is concerned. PCNL, even as a matter of fact, RIRS may not tolerate bleeding like adults, whether it is PCNL or anything. As part of the evaluation, you do ultrasound, urine culture, IVP or low-dose CT, but most important is focused metabolic workup. If you see metabolic workup, it is more every time you see the child, you have to keep in your OPD chamber and do it. The one problem in children less than 2 years is 24-hour urine cannot be done easily. So spot urine test gives some guideline. Once the child grows, then you can do 24 hours urine once the toilet habits are developed. The important is cystine stones you should not miss. That's why the look of the stone is also important when you are doing the surgery. Most of us know what type of stone it is usually. Coming to the technical aspect which I am supposed to speak, preoperative stenting in all cases. I have 3 literatures available we have done in really small children, that is less than 1 year, 1.5 years, in which one is from the China, another is from the Turkey, 2 published articles in urology. They all stented, so it is an undoubted fact that you have to stent so that the ureter damage is less. Sheathless is better. Drainage of bladder. Children have small bladder. Use one suprapubic catheter to aspirate. It is easy, safe and not traumatized to the bladder as well as to the flexible scope. RGP at the beginning, at the end, gentle RGP with 1 ml diluted contrast is better. Smaller access sheath if at all you want to use, better. Next, So technical aspect is over and double guide wire is better. General anesthesia is always preferred. Fluid management should be done by the pediatrician or pediatric nephrologist or a good anesthetist. Now, normal caliber of the urethra is less than 8 French. You have to remember that if you want to go in a male small children, 1 day before catheterization is better than forcibly introducing 10 by 12 or 12 by 14. Disaster. Small urethra in male penis cannot be injured. This is a major limitation. Ureter can accommodate, but not urethra. If you come to the volume of the bladder, it is less than 150 ml. The moment you inject 2 saline bottles, 20 ml, bladder will be full. So never drape completely the child. You keep on palpating in the beginning and every 5 minutes so that when the bladder, even if after taking out aspiration, it may fill because your aspiration may not be that fast. Now coming to the normal caliber of the ureter, 7 French. That means if you stent, it will become 10 French probably. But if you go directly, there is chance of injury to the ureter. We have to keep this in mind. Access sheath placement, some people have kept it in post-stented. It is easy because it is dilated. Unlike urethra, ureter is slightly distensible after the stent, so it can be put. Any dilatation methods, they already proved that access sheath can be put. In dilatation methods, none have recommended dilatation in children because dangerous perforations and avulsions can happen. So better option is stent only. Passive dilatation is better. Few attempted with balloon dilatation, but their reported literature incidence of perforation is high. Now coming to the risk of ureteric injury, slightly higher than in adults naturally, 3 to 7%. Usually it is less than 1% in adults, but here it is 3 to 7, 1 to 6, 1 to 12% stricture. That is not good in long term. Now our experience, we have done 10 cases, out of which 2 failed and converted into PCNL. 8 cases less than 2 years, smallest is 4 months baby. Rest all I will show in the our stone free rate is 87%. Most common problem is tight ureter. Whenever tight ureter which is not admitting 6 by 7.5 ureteroscope, better to stop the procedure. That is what recommended in papers also. With this, there is only one scope available, that is also short length, not short diameter, from collar stone. That means there is no specific scope introduced so far, flexible ureteroscope for any child. That is unfortunate. And to aspirate, you use an intracath where you put suprapubic when the bladder is full. The only problem is it flexes. When it flexes, you lose the track and it will come out. Again you repuncture, nothing will happen. This is only 18 gauge intracath which used for the venous cannula. Now coming to the sepsis definition, total leukocyte count, tachycardia, bradycardia, various definitions are there. You should go with a good neonatologist. And it is a multidisciplinary approach. Postoperative IV fluids, as a urologist you may not be well versed unless you are working in a pediatric urology setup. Pediatric ventilator, pediatrician are essential. Now there are 3 papers I already told. They all have done in less than 2 years. Smallest baby is 7 months. We have done 4 months baby. Now this is my first surgery. This surgery shows that this baby is only 4 months. To my surprise, this has come to the pediatric institute government, where presented with bilateral ureteric stone obstructed and anuria. They have stented it. I don't have option to go at least in one side and see whether one ureteric stone and kidney stones can be removed. So ureteric stone, it is not good for ESWL, and multiple stones not good for ESWL. When I am trying the guide wire, you see here, even if it is dilated, post-stented 1 month, it was not going. So certain maneuvers are used. Once I enter into the ureter, some mug with stones were there. I kept 2 guide wires. Even then, my flexible ureteroscope did not go easily. The basic reason to show what are the negative points here is that, see, this is where you are aspirating the bladder. Now I am passing without access sheath flexex. See, it is not going. It is not going. And it is not going, slipping. These are the small injuries can injure the bladder also. Then I kept ureteroscope for 2 minutes or 5 minutes. Listen some music and be patiently wait. This is the last attempt you can do. Now I passed. It went easily. Now after going inside, it is same. Only problem is, normally if you have access sheath and a long penis, you act as the left hand to hold and then move. Here it is not there. Small penis, you put hand on the suprapubic region and try to control. Your movements may not be reflected as easily inside as outside, you think. So fine movements, that's why painting is not that easy. You do popcorn. Paint for distension of the pelvis also will not be there. Low pressure settings, the laser settings are important to avoid heat damage. It will take little time. Only clue that the child is doing well is your aspiration. If you are aspirating the fluid very clearly without any distension of the bladder, then it is fine. If your bladder is not full and your fluid is going, where will it go? Intrarenal reflux, perforation, ascites are very common in children. We have seen in one case ascites. If you cover too much the baby, you don't even realize. Anesthetist will tell that the pressure is rising. So now small stent, I am threading over the guide wire. Even though it is 16 centimeters, it is too big for the child. We don't have less than 16 centimeters. Now I am moving on to the left side. Ideally you should not do on both the sides, but because one side it went easily, without any problem in 15 minutes. I removed the guide wire and passed the same. This time I faced problem in the upper ureter. In children, usually upper ureter is highly mobile. When you pass the flexible scope, you feel some resistance. Now it is going, it's going, now it's going. Now when you see here, it is flexing. That is dangerous because upper ureteric injury is equal to sometimes nephrectomy because repair is not easy. Then certain maneuver is done where the lumen is kept as the aim, and extreme maneuver of the hand is done so that it went inside over the two guide wires as railroad. Then multiple stones were there, all are done. This patient shown has come the uric acid stone. We evaluated, this is now 1 year child, he is doing well. We kept him on alkalizers as well as allopurinol also along with the nephrologist pediatric. Now child is doing well. This is published recently published because this is the smallest child to undergo RIRS. Now I will go to the next surgery. At the end we have done CT for academic purpose. That clearly shows that there is no stone. See, there is some nephrogram phase at the end. If you see that, I might have not done on the opposite side. Thing is that you should be safe. This is a CT, and I will go to the next slide. Now my next slide is again 1 year. This is published in Elsevier article, and yeah, I got the beep, so I will take this is 1 year male baby. I will play this video. I have 2 minutes time. So in this 1 year OB, it is similar. You have done bilateral 1.5 centimeter on the right side and left side. Only small important point to mention is if your access sheath is not going into the ureter, is 1 year. So keep it in the bladder and have a guide wire. But only thing is that too many times if you remove, it is very difficult in children. Last piece, when it is there inside the PCS, take it for the stone analysis. It is mandatory. So here I am going without guide wire, nothing great. Because the ureter was accommodable, I am easily going. See, this is a big stone, but so nicely powdering, even if you are not touching, it is because they are uric acid stones most of the times in India, low socioeconomic status. Otherwise, calcium oxalate, monohydrate and dihydrate combination stones are more. Once this is completely powdered, then other side is done. You can use the access sheath also. We have done 2 children. There is no problem. But only problem is urethra in male. Now I will go to the female where you can do the dilatation. I will go to the slide. This is a female child where go to the girl. This is a girl child where you can do dilatation with a small dilator. The reason to show this is, first, this is a large dilator, up to 12 French you dilate. So slightly you are more comfortable with female children. So you go with ureteroscope, always 6 by 7.5 ureteroscopy, then thread over it. Once you are inside, procedure is same. Now, once you have seen the stone, you can do. And now here, because female, I kept a feeding tube for the aspiration. Go back to the slide. Now I am going back to this slide. These are the 3 cases I have shown the videos. Now coming to the one year male baby, 1.5 years male baby is there. Failed cases, how it failed, I will show. This is the, I have done stenting, I went inside, dental RGP has shown intra perforation, then it has shown contrast leak. Immediately PCNL is done, consent is taken because one more anesthesia is problem. This is the case 1 failed case. Again it is going back. This is case 1. This is the position where supine PCNL is done, and then case 2 again it is done because of the perforation in the calyceal system. Then prone PCNL is done. So you should be mentally prepared for both. This patient is done. So conclusion: SFR is comparable to PCNL and DSWL. Small studies, only 3 studies are there, less than 2 years, less hospital stay, less radiation exposure. The conclusion for negative things are technically challenging. You have to be careful. Small scopes have to come. Small laser fiber have to come. Multiple sessions are needed. You have to keep in mind minimum 3 sessions. With that, thank you once again for giving this opportunity. If you have any questions, we will take at the end. Thank you very much.